Hello, doctors. I'm Dr. Chris Rapoff of QME Continuing Education, and welcome to this week's presentation. This is the second and final installment on the topic of basic pain mechanism and its control, particularly for the lower back. Now, once again, this information was taken from the textbook that was entitled Musculoskeletal Disorders in the Workplace in 1997. This particular chapter was authored by James N. Weinstein. Let's get started. Well, first, let's do some reviewing. Last time, we touched on 4 different sources of lower back pain, and we're going to discuss 2 more today. But first of all, we discussed the intervertebral disc, and we found that research indicates, unsurprisingly, that the disc may be a primary source of low back pain, but the mechanisms of the pain production are pretty uncertain. Now, we also discussed facet joints. Now, these joints we know are richly innervated and they undergo extensive stretching during the physiologic loading. They too play a large role in low back pain. Muscles, though, most common diagnosis for lower back pain is acute sprain strain. But scientific evidence for lower back pain of muscle origin doesn't exist, or it's very lacking. And finally, we discussed lumbar nerve roots. And the researchers did determine that compressed and inflamed nerve roots were very sensitive to mechanical manipulation. Now, today's discussion, we're going to touch on the chemical mediators of nociception and neurogenic mediators. Here, the first of our 4 sources potential pain producers are what one generally thinks of when they talk about and discuss potential causes of lower back pain, especially as we address the applicant in a PQME examination setting. Now today, we'll touch on 2 more potential causes of lower back pain, the neurophysiological causes of pain, namely the chemical mediators of nociception and neurologic or neurogenic mediators. First, let's do a little brushing up on our neurophysiology. Now, let's put our thinking caps on and try to remember some pertinent facts here. Now, first of all, the sensory nerve fibers are often assigned to 1 to 4 groups, 1 through 4, based on their conduction velocity. Group 4 consists of unmyelinated C fibers, and Group 3 includes the thinly myelinated A delta fibers. In general, the pain fibers belong to either Group 3 or 4, but not all Group 3 and 4 fibers are associated with muscle pain. Now, researchers reported on the activity of Group 3 muscle units from anesthetized cats. Group 3 fibers were low-threshold pressure-sensitive units. Nociceptive and contraction-sensitive units were also seen. Now, Group 4 units included nociceptive, low-threshold pressure-sensitive, contraction-sensitive, and thermosensitive units. So you see they're very important. Now, in these small diameter afferent nerves, non-nociceptive units outnumbered nociceptive units 62 to 38%. Non-neurogenic pain mediators, such as bradykinin, are known to excite muscle units. Now, this has been shown to be an excitement of the afferent fibers from muscle groups 3 and 4. Prostaglandin E is known to enhance this action as well. Inflammation-induced myositis is known to increase the neurophysiologic background activity of Group 3 and 4 units and is associated with lowering of the threshold of Group 4 units, so it's very important. Several neurophysiologic investigators have demonstrated inflammation to be an agitator when it comes to nerves and joints, making them more sensitive to movement than normal joints. That makes sense. We see in our practices and in our QME examinations. Now, researchers such as Kavanaugh have studied the lumbar facet joint and the ankle joint, and it's been studied with inflammation models. Some of these models have demonstrated that the Group 3 and 4 units are more sensitive to stretch and have a higher resting discharge rates than do the controls. Additional research found that Group 4 units were much more readily activated by normal joint movements in inflamed joints than in normal joints. Now, over the years, there have been a great deal of interest in the lumbar facet joints, as we discussed last time. But limited work regarding the neurophysiology and the possible sources of pain to those still exists. So to that end, a group of researchers have undertaken a series of neurophysiologic studies in rabbits. And these studies have indicated that the facet joint capsule, or the paracapsular area in the adjacent musculotendinous junctions, contains both low and high threshold mechanoreceptors. Low threshold receptors are proprioceptors, and high threshold pain receptors. Localized injection with synthetic substance P, which is a neuromodulator of pain, also activates nociceptors and proprioceptors in the facet joints and the deep back muscles. Bradykinin and serotonin chemical mediators of inflammation also activate the nociceptive units in and around the facet joint. Loading the spine can also activate high threshold units and phasic units, but it really can't be maintained. However, on the other hand, chemical mediators do maintain the discharge. Mechanosensitive units in the rabbits were found in the multifidus, rotary, and intermaxillary muscles, as well as in and around the facet joint capsule and border regions at the junction of the capsule and musculocutaneous insertions. Inflamed units often showed vigorous multi-unit response to stretch and demonstrated a decrease in the discharge rate from the inflamed tissues when lidocaine or hydrocortisone were applied. Preliminary work on neural activity within the spinal canal was reported by researchers as well. Once again, Kavanaugh. Yes, Kavanaugh has seen the activation of mechanosensitive units from the dorsal roots after various mechanical manipulations and application of analgesic substances to the lumbar in the disc, or the posterior longitudinal ligament, actually evokes a neural discharge. Now, pulling of the ventral dura was accompanied by a multi-unit activation. It's hard to know whether these dural units themselves are responsible or adjacent tissues that receive traction when the dura is pulled. Now we'll discuss the chemical mediators of nociception. First, we have to get some background. Chemical inflammation is often mediated by amines, which would include histamine, for example, kinins, which would include bradykinin, arachidonic acid derivatives, which would be prostaglandins, kinin-forming enzymes, which would be chylocreatine, plasmin, and products of the complement system, and components of polymorphonuclear leukocytes. The major pain-producing substances involved in inflammation still appears to be related to reactions of bradykinin, serotonin, and prostaglandin E, which we discussed in the last slide. In a study on human volunteers, intradermal injection of histamine and bradykinin produced short-lasting pain, but prolonged edema and erythema. Bradykinin has also shown to excite group 3 and 4 muscle afferent fibers, and subdermal injections of prostaglandins and histamine or bradykinin are associated with intense pain that is considerably greater than when the agents are injected alone. Now, aspirin, which is known to block the synthesis of prostaglandins, may produce its analgesic effect by preventing the sensitization of pain receptors to prostaglandins. Leukotrienes are chemotactic for polymorphonuclear leukocytes that accumulate in areas of inflammation, and when injected intradermally are known to sensitize C nociceptors to mechanically stimulate and cause hyperalgesia. These substances are not affected by non-steroidal anti-inflammatory drugs, which normally block the cyclooxygenation of arachidonic acid. On to neurogenic mediators. Substance P. It's an 11 amino acid polypeptide that's identified immunohistochemically in various regions of the peripheral and the central nervous system, as well as the functional spinal unit. Substance P is also thought to play a major role in the transmission and modulation of pain signals. Release of substance P to and from the dorsal horn is reported to increase during acute noxious mechanical stimuli and in a polyarthritic state. Keep in mind, substance P is also instrumental in producing the symptoms of chronic regional pain syndrome that I've discussed in a past presentation. So sensitization as a result of substance P on a peripheral nerve endings hasn't really been resolved. However, substance P may contribute to the transmission of both nociceptive and, in some cases, proprioceptive sensations in the primary afferent units of the lumbar facet and adjacent soft tissue. Now, causal links between environmental factors, such as vibration, for instance, and functional unit degeneration mediated by biologic events are currently being investigated. In this model, it's proposed that the neuropeptides released from the dorsal root ganglion induced by environmental and structural factors mediate a progressive degeneration of the functional spinal unit by stimulating the synthesis of inflammatory agents, e.g. E2, and various degradative enzymes such as the proteases. This now weakened functional spinal unit is increasingly susceptible to environmental factors, which in turn lower the threshold necessary to stimulate the neuropeptide activity, thereby perpetuating the degenerative spiral. In the work by Levine, Lotz et al., arthritis was induced by an infusion of substance P and was decreased or inhibited by substance P antagonists. So if substance P is released in and around the functional spinal unit, it's therefore, in theory, capable of stimulating or activating various proteases that in effect degrade collagen and negatively affect the mechanics and the collagen and negatively affect the mechanics of the functional spinal unit themselves. Well, I realize, doctors, that was a lot to digest, and I appreciate your patience. But in summary, let's discuss this. So, in a classic model of disease, patients often have symptoms and significant pathology. We do know that. However, more often than not, patients have many symptoms and little pathology, or a great deal of pathology and no symptoms. In occasional low back pain, it's more challenging to consider the psychosocial aspects of their effects of the perception pain. Now, those issues have been poorly understood, but clearly the injured tissues are capable of being a source of chronic pain. On the other hand, psychological factors, which we didn't discuss in this presentation, can create a spinal pain unrelated to the routine or unexplained injury and repair processes. The lack of understanding of the perception of pain and how our perceptions interact in the development and manifestations of pain itself still remains unknown. But in the United States, 1 family in 3 includes someone suffering from pain. Pain is not necessarily related to an injury. In some cases, it can be related to an emotional response that may be more painful. However, with proper education, appropriate expectations, and comprehensive approach to diseases and pain management, the majority of our patients can expect a successful outcome. Still, in many cases, residual pain must be expected and be dealt with. Through a better understanding of pain itself, the pathophysiology, neurochemistry, anatomy, and psychology of pain, we still must continue to seek more efficacious and responsible therapies for back pain sufferers. So, doctors, I'm Dr. Chris Rapoff, and I wanted to thank you for taking the time to join me in this presentation. I hope you enjoyed part 2 of this 2-part presentation dealing with the basic pain mechanism and its control. your QME examinees. Until then, thank you.